Pelvic tenderness. It's really important to check all of the organs, the uterus, fallopian tubes, the ovaries, vagina, the bowel. Don't forget the bowel, the bladder, peritoneal cavity, retroperitoneum, and even the pelvic muscles. So the uterine causes of pain, well, they can be related to the endometrial canal, such as hematometra, which may be congenital or acquired post-endometrial ablation. It can be due to inflammation, endomyometritis, can be related to myometrial difficulties such as adenomyosis, misplaced IUD, or fibroids. Now the reason I've written fibroid as a very, very small word is that the incidence of tender fibroids in the non-pregnant patient is very, very, very low. And so fibroids, for the most part, are not a cause of pelvic pain. Well, let's just look at various issues. Congenital causes, congenital hematometra. Here's a 16-year-old patient with a large abdominal pain and a large abdominal mass. And the only interesting thing really is that she has regular periods. So let's look at the top of this mass, and on the top you see a thick-walled oval mass with low-level internal echoes. Just to the left of midline, it is avascular on Doppler, and in fact on transverse scan, as you can see on the diagram, you can see a cystic space on the right, or on the patient's left, and on the right you can see what looks like a more normal appearing uterus with a small empty endometrial canal. And what this patient has actually is two uteruses, a didelphic uterus with a double vagina. The left side of the reproductive system is occluded by an imperforate hymen, and so she has hematosalpinx, hematometra, and hematocolpos on the left, but her right uterus is quite normal, and that's why she is having normal periods. She also has only a single kidney on the right side with some hydronephrosis, no kidney on the left side. So to review, she has two complete uteruses, two fallopian tubes, two vaginas. The vagina on the left is obstructed, giving you the large mass, which is the hematocolpos. She has blood in the endometrial canal, giving you hematometra, blood in the fallopian tube, giving you hematosalpinx. Well, the treatment is easy. The gynecologist takes a scalpel and incises the distended hymen, and all of the blood rushes out. And now you can see on transverse scan through the now normal sized uterus on the left and the normal sized uterus on the right, they look identical. The endometrial canals are both empty. You can see that on longitudinal section on the right and left, the uteruses look normal. And as we sweep from the cervix up to the fundus, you can see the endometrial canals, nice and normal, with no fluid in them at all. So a beautiful example of a didelphic uterus post-treatment. So this patient had the hematocolpus, hematometra, and hematosalpinx all drained away. And not diagrammatically. In another patient, this is what it might look like. You have the uterus on the left and cervix on the left, and on the right, each one having their own fallopian tube and ovary, and not included, of course, would have been the vaginas, the two separate vaginas in this particular patient. Now we have a 49-year-old patient, had 4 pregnancies, comes in with left-sided pelvic pain, and has a bulky uterus with heterogeneous myometrium, an endometrial canal, and a somewhat eccentric cystic mass with low-level internal echoes. Well, what is it? First of all, The clue is to look at the myometrium. The myometrium is heterogeneous with changes absolutely typical of adenomyosis. Is there a question that you might want to ask this patient, such as, have you had any previous surgery? And she says, yes, I have had amenorrhea, but still some pain since my endometrial ablation a year ago. So here's a patient who had menorrhagia, had an endometrial ablation in a situation where she has adenomyosis, and she has developed a cystic mass within the myometrium. Now, it would be, you can see this beautifully in the transverse scan. There is the cystic mass within the central portion of the uterus, the adenomyosis, which gives you a heterogeneous myometrium, and also distension of the intramural portion of the fallopian tube, a hematosalpinx, very typical in this patient. Now, or not uncommon in patients who have had endometrial ablation with, in the face of the adenomyosis. What was interesting is that I got a call from the operating room where the gynecologist was doing a hysteroscopy. He put a tube in the endometrial canal and called me, and he said, I cannot see a hematometra. The endometrial canal is absolutely clear. In reality, what's happening is that this patient with adenomyosis has a adenomyotic cyst within the myometrium beneath a scar. And so when I went in there with the probe from the transabdominal approach, I could see his scope. I could guide him towards this cyst that was causing pain, and he was able to put in a small knife and drain the cyst. So just remember, it's very easy to call these acquired hematometra, but in fact they're not, and it will be confusing to the surgeon, who will expect to see this when they do a hysteroscopy, and it's just simply not there. So even though I've called it a hematometra, it's really a myometrial adenomyotic cyst. So congenital and acquired hematometra is one of the causes of pelvic pain. Here's another example, exactly the same, post-endometrial ablation, this irregular adenomyotic cyst with the heterogeneity of the myometrium and a previous endometrial ablation. Very, very typical. When you see that large cyst, think of post-endometrial ablation adenomyotic cyst. Here's another patient. Almost looks like a gestational sac, but again, endometrial ablation, heterogeneous myometrium, and in the scan she also has distension of the intramural portion of the fallopian tube. Again, an avascular structure. So hematometra, adenomyosis. Next is in patients who have endometrial ablation. Don't think that the endometrial canal is in fact occluded. In some cases, there is synechial bands and an Asherman's type syndrome where there's absolutely complete obliteration of the endometrial canal, but not in this case. This patient had, in fact, hematometra. This was a true hematometra where she did have blood collections in the endometrial canal. Obviously, they've drained away on this coronal view of the actual specimen. What's also interesting is on the longitudinal scan of the uterus in this patient with post-endometrial ablation and adenomyosis, you can see the echogenic endometrium, but in fact, it's not endometrium at all. It's actually just scarring of the myometrium, but it looks like what you would expect endometrium to look like. So be very, very careful when you're looking at these post-endometrial ablation patients. Patient who had had an endometrial ablation and has a large distended endometrial canal that was very tender. She was having pain. We did a 3D scan, and then we removed the uterus. So the gynecologist removed the uterus, and as you open it up in the coronal view, you can see the blood draining out, and then the coronal view of the uterus shows that big distended endometrial canal from a large blood-filled cyst following endometrial ablation. Now here is a wonderful, wonderful case. Here's a patient who has pelvic pain 1 year post-endometrial ablation, and you can see that she has this heterogeneous myometrium, areas of increased and decreased echogenicity. She has a myometrial cyst, but she has this large echogenic mass. And you might say, well, you know, maybe this is a polyp or regrowth of the endometrium, and probably give a list of 5 or 6 different things. But in this particular case, if you just sit and watch the uterus, watch what happens to the uterus, the diagnosis is absolutely very simple. And here you can see that this is a hematometra or an adenomyotic cyst, and this is actually blood filling in the cyst and swirling around. This is fresh blood, which we know is echogenic. So the diagnosis here, because you just sat and watched the uterus, is very, very simple. It's just, again, a adenomyotic cyst or hematometra in a patient with adenomyosis and post and previous endometrial ablation. Here she is again, and 1.5 years later, she came back for a follow-up, still has the heterogeneous myometrium. That cystic mass is gone. There's a small amount. I asked her, you know, have you had a procedure? Or did you have bleeding? Did you have a gush of blood? No, 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 nothing. So it obviously just simply reabsorbed. She also has blood in the intramural portion of the fallopian tube. So hematometra just simply resolved.